All right, so we have typical versus atypical antipsychotics here. I am going to probably skip that. Okay, we have extrapyramidal symptoms on top. I will skip that. Okay, and then the main thing I want to focus on right now is CAP and HAP. We have CAP, community acquired pneumonia. We have HAP, hospital acquired pneumonia. Now, there is another dynamic to that. With the with types of pneumonia that we also have outpatient and we have inpatient. Okay, and then we also have another category. We have complicated and uncomplicated. So this makes the entire pneumonia story a little complicated, but let's simplify it. So let's quickly talk about outpatient setting. For the outpatient setting in a LD, outpatient in a LD person, type in the chat for me. Outpatient in a healthy person, does it mean complicated or uncomplicated? How do you approach it? Pneumonia in a patient in an outpatient setting, but the patient is healthy. Is that complicated or uncomplicated? To save time, it is uncomplicated. It is uncomplicated because the person is healthy. That's it. The exam will not say complicated or uncomplicated. They will use the word an adult patient that is healthy or a kid that is healthy. They will put the word healthy there. Okay. How do you treat that person? Amoxicillin high dose, 1 gram TID, or doxycycline or macrolide. Azithromycin or clarithromycin if local resistance less than 25%. So if they ask you for the very first line treatment, amoxicillin is generally written on the exam. Now, why do we choose second line? Second line is something that we try to treat with first line. When things is not going well or something, we now have to go and choose something stronger, and that will be the second line, fluoroquinolone. So if we choose fluoroquinolone, it's because we absolutely have no choice. Only choose fluoroquinolone because you have no choice. Okay. Fluoroquinolone, first of all, it can cause Achilles tendon rupture, and it's one of the drugs that also can cause, it's very strong, and we reserve it for really big issues, so that we don't have people dying because we don't have meds to treat them. Because the more exposed we are, or the more we expose these drugs to antibiotics, the organism will start fighting against it. Special population, amoxicillin or azithromycin, you want to avoid doxycycline and fluoroquinolone in this special person. So for someone that is pregnant, amoxicillin or azithromycin is perfect, but avoid doxy and fluoroquinolone. Now, we just finished talking about outpatient. We're now going to go ahead and talk about outpatient with comorbid condition. This is outpatient that is non-complicated. We're now going to talk about outpatient that is complicated. They are complicated means they have comorbid condition, right? So now, what do we need to treat this person? First line, amoxicillin clavulanate or cephalosporin plus macrolide or doxycycline, or respiratory fluoroquinolones monotherapy, levofloxacin, moxifloxacin, gemifloxacin, fluoroquinolone alternatives. If they are allergic, you got to use doxy or fluoroquinolone depending on the risk. That will be the second option. If you absolutely have to choose a second line because you don't have a choice, that is when you choose this. Don't forget, we're doing respiratory system. You can't escape respiratory system without focusing on this acute care part. Okay? Now, elderly, you want to avoid fluoroquinolones unless necessary due to Achilles tendon rupture risk, and of course CNS risk. Let's talk about inpatient. Non-ICU, inpatient, ICU. Okay, so inpatient, we have 2 levels of inpatient. We have med-surg, right? We have critical care, right? So now inpatient non-ICU, beta-lactam, ceftriaxone, cefoxamine, ampicillin plus macrolide or respiratory fluoroquinolones. We can use them as single therapy, which is monotherapy. Now, beta-lactam plus doxy if macrolide allergy. So for those drugs, sometimes we have patients with allergies. We have to also provide the alternative. At least we're not going to watch a patient die because they're allergic to a particular drug. So let's go back to the beginning. Outpatient, if they are LD, amoxicillin. If we don't have a choice, fluoroquinolone. In a pregnant mom, avoid fluoroquinolone and doxy. You got to do just amoxicillin or azithromycin. In an outpatient, with those with comorbid condition, you want to do combination therapy like amoxicillin and clavulanate or cephalosporin plus macrolide or doxycycline, or respiratory fluoroquinolones monotherapy like levo, like moxi and gemifloxacin. If they are allergic though, you can use doxy or use fluoroquinolone. Now, in an inpatient, now we have two people. You got to be watching the people that they are asking on the exam. What category of people are we talking about? Okay, inpatient who? LD or not LD? Outpatient who? LD or not LD? Very important. You see, that's why I broke it down like this. Now with inpatient, and this is in your canvas. Inpatient, beta-lactam, ceftriaxone, cefoxamine, ampicillin, macrolide or respiratory fluoroquinolones, and then beta-lactam plus doxy if macrolide allergy. If they are pregnant, beta-lactam plus azithromycin is preferred. Okay, so now inpatient ICU, severe CAP, beta-lactam, ceftriaxone, cefoxamine, ampicillin, sulfobactam, azithromycin or beta-lactam plus fluoroquinolone. If penicillin allergy, levofloxacin plus azithromycin. Okay, so that will be the second line. Keep that in mind. If they have allergy for any reason, you want to do levo. And when we are doing and transitioning, like if they have penicillin allergy or if they have some kind of allergy, watch what you are transitioning into based on the kind of care that you are given. Who are you treating? When it comes to pneumonia, it's about who are you treating. Who you are treating will determine what you give. Who are you treating, meaning what kind of patient do you have in your hand? Do you have a patient that is very, very sick, or you have a patient that never have any history? Do you have an inpatient in your hand, or do you have an outpatient in your hand? So pay attention on your question, okay? So for special people, if we suspect MRSA, we want to add vancomycin to the treatment or linezolid. Pseudomonas suspected, you want to add zosine. That is piperacillin tazobactam, cefepime or meropenem. So depending on what we are suspecting in an inpatient ICU with severe CAP, you got to also pay attention to, are we suspecting MRSA? Are we suspecting Pseudomonas? You're also going to add something else to it. Please type yes in the chat if you're understanding what I'm saying, or do I need to go back and repeat myself? So we do have some that are drug resistant, right? Generally, hospital acquired, because it's hospital organisms. Think about, they're like criminals. You know, they have dodged many bullets. You see that now? So many of them are resistant, so they are very hard to treat. So hospital-acquired pneumonia, we're going to be doing zosine, cefepime, levofloxacin, imipenem, or meropenem. If you're like, hey, what the heck is this? What's the drug and class of this drug? I'm not trying to hide drug and class here. It is under your what? Your antibiotics lecture. So for this to make some sense to you, review your antibiotic lectures first. Know their drugs, know their class, know where these things belong, or quickly look it up somewhere else if you don't want my lecture. My lecture is only an hour and a half for antibiotic, I think. And then come back here, and then this will start making more sense. So what is the alternative? What is the second line? Adjust by per local antibiogram. So whatever is going on, you're going to adjust it. That will be your second line for that. For pregnancy people, which is a special population, you don't want to give fluoroquinolone any day, anytime, anywhere. And then use beta-lactams if it is safe. If it's, you have to assess, it's gonna be a case-by-case basis. What about HAP with risk? You see what I'm saying now? We got two main types of pneumonia, CAP and HAP. We have like 4 different types of CAPs and HAPs. We have the one that is outpatient, inpatient. We have sick and not sick. That is how you have to group it in your head too. So now with HAP, now we say HAP now with risk. For him to HAP with no risk. So we're kind of saying here to HAP with, they carry a lot. They are using ventilator. They have all kind of drips going in. They have all kind of veins puncture. They are probably triple lumen. You know, they have ARDS as well. So they are sick people. So in these people, we have to use 2 anti-pseudomonal agents from different classes, like cefepime plus levofloxacin. Your foundation is key. If you don't know your where your antibiotic lecture is, stand by. I'm going to show you. Or Zosyn plus MRSA coverage of vancomycin. Don't be trying to put mnemonics on this. You'll have to repeat it many times and you're going to be good. You want to adjust per culture and sensitivities. That will be there is no second line. You want to adjust your dose, go up or go down based on what you're getting. Is it clearing? Then start backing off. Is it not clearing? Start thinking of something else to add. Or start thinking of another route to take. Antibiotic, I said, we are actually shooting things. So we must be shooting the right things. If we don't shoot the right things, the patient may end up dying because the organism will end up invading the host. Now, immunocompromised, broader empiric coverage. Consider antifungal or viral if indicated. Okay, now let's take a look at my PERS. Kehinde Elisha's PERS. CAP outpatient in a healthy patient, amoxicillin, doxycycline, or macrolide. I call this one ADM or AMD, or I'm doctor, AMD. Whatever you want to do. Say, what about CAP? Community acquired pneumonia outpatient, augmentin plus macrolide or doxy or fluoroquinolone. If you have to give fluoroquinolone, pay attention now. You got to give it alone. That's a very strong antibiotic. And only give it because we have to give it. It's a very strong drug. We don't give it just anyhow. It's a big guy that we try to save for something huge. Now, what about inpatient non-ICU? Beta-lactam plus macrolide or fluoroquinolone. Inpatient ICU, beta-lactam plus azithromycin or fluoroquinolone. Hospital-acquired pneumonia, broad empiric what? Anti-pseudomonal plus MRSA. You got to escalate if they have MDR risk. If we have organism that is going to resist it, we need to go ahead and do what we can do to keep fighting it hard. Always de-escalate once culture returns. So now we do treat prophylactically, and then before we give medication prophylactically, we want to draw cultures first, send it out, and start shooting them with the antibiotic. And then when we start shooting them with antibiotics, we now repeat another culture. We see what the culture reads. If things are getting softer, we need to go soft too, because we still have to kind of guard those bullets, which is antibiotic, to make sure that we don't run out of ammunition. That is how you have to say antibiotic. We don't want to run out of ammunition, meaning we don't want to run out of options of what to use, because now a lot of organisms are resistant to it. Let's take a look at these questions. This is how you're going to see your question. A 58-year-old man with type 2 diabetes and chronic heart failure presents to the emergency department with fever, productive cough, and green sputum, shortness of breath, and pleuritic chest pain for 3 days. On exam, he is tachypnic, hypotensive, and has crackles in the right lower lung field. Chest x-ray shows lobar consolidation with a small pleural effusion. So question 1, which feature makes this CAP complicated? A, fever. B, productive cough. C, presence of comorbidities and pleural effusion. C, crackles on lung exam. So this question, let's take a look at this question first. Okay. This is pretty much telling you to identify that, okay, these symptoms you're looking at, what makes it really bad? What makes it a complicated case? Is it the type 2 diabetes? Is it the chronic heart failure? Is it the fever? I think everything makes it complicated in my opinion. But it says this particular CAP, what makes it complicated? We're picking comorbid conditions, pleural effusion. That will make sense. And that is what makes it complicated. It's just trying to explain to us what complicated is, which we already spoke about. I think this is a breeze for everybody. Productive cough, fever, these are technically temporary things, but some things are permanent. Comorbids are permanent, like type 2 diabetes, chronic heart failure. Those are comorbid conditions. Two different things. So fever, cough, crackles are common in uncomplicated. So these are normal, regular, day-to-day symptoms. I hope we now understand what complicated is. Now, what is the most appropriate initial treatment approach for a patient for this patient? A, outpatient oral amoxicillin. B, outpatient macrolide monotherapy. C, inpatient IV macrolide beta-lactam plus macrolide. D, observations only. They say, what is the most appropriate initial treatment approach? What is the most appropriate initial treatment approach? Now, your initial treatment approach will be based on what we have on top. We discussed already, and it's going to be inpatient. Don't forget, it's complicated. It's complicated. So look at the options. A, outpatient oral amoxicillin. B, and many students will jump on that if they forget what complicated is, or if they overlook the complicated aspect. Okay, amoxicillin would have been ideal if it is an uncomplicated case. So that was a trap right there. Now, outpatient macrolide monotherapy, that would be wrong. We need, in addition to mono, we need something else plus macrolide. Inpatient IV beta-lactam like ceftriaxone plus macrolide. Observation only, that will not pass. So C is the final answer here. We're just simulating this to see how this works. That this patient is at high risk due to what comorbidities. This patient is dealing with CHF already. They are dealing with diabetes already. You know, so signs of complicated CAP includes what? Pleural effusion, hypotension, and hypoxia. So guidelines recommend inpatient therapy to be what? IV beta-lactam plus macrolide or fluoroquinolones monotherapy if beta-lactam is contraindicated. Let's look at question number 3. Which symptom is most indicative of a complicated course of CAP? A, mild fatigue. B, pleuritic chest pain with effusion. C, low-grade cough. D, occasional headache. So this one says, which symptom is most indicative of complicated course of CAP? The complicated course, like pretty much saying, you know, how bad is it? Like something that makes us, something that you have to like put a lot of work into. The pleuritic chest pain with effusion is worth putting a lot of effort into, because pleural effusion or emphysema signals complicated infection right there. Infection will now lead to other things, which is going to be like unending. You're going to be chasing it until, you know, until the end of the world, like if you don't step it up. So it often requires inpatient care. They have to drain out that fluids and do antibiotics. Now, Dr. K is right here. For complicated CAP, don't forget comorbidities plus complications are effusion, abscess, and sepsis. That is bad. We need to prevent it from getting to that level. Treatment: inpatient IV antibiotics, beta-lactam plus macrolide or fluoroquinolone. Key symptom pointing to complication: pleuritic chest pain with effusion or signs of sepsis. Now, complicated versus uncomplicated in adults. Now, this is HAP. Okay, here I only talk about CAP, and I talk about small little HAP right here. So I came back and did a little bit of an extensive HAP to make it look like my CAP. So I have my uncomplicated CAP, and I try to give it a definition. You know, occurs more than or equal to 48 hours after hospital admission in patients without risk. You know, complicated HAP is patient with risk factors like MDR, pathogen, or severe illness, you know, and so on and so forth. So I kind of expanded this one to let you see what organisms are responsible for both MRSA, Pseudomonas, and all that. And I also have treatment here: monotherapy with zosine or cefepime or levofloxacin. That is for uncomplicated. For complicated, we have 2 anti-Pseudomonas agents from different classes like cefepime, aminoglycoside plus MRSA coverage, vancomycin or linezolid. And then we do have some special notes right here that people with HAP that are uncomplicated, they usually respond to standard empiric coverage reassessed with cultures. With complicated though, you gotta be aggressive. Aggressive empiric therapy will work. De-escalate based on cultures. Monitor renal function due to nephrotoxic drugs. And then I have uncomplicated HAP, standard empiric therapy, complicated, broad spectrum. So that is it. Then I have some questions here just for HAP, and you have that to do once you're done. It's only 2 questions to tell you what your question look like. It's a big difference. We just don't treat pneumonia. We're focusing on what type of pneumonia are we treating, in whom are we treating it. What type of pneumonia is it? Is it a complicated pneumonia or uncomplicated pneumonia? You got to have all this and pay attention even under that pressure. Examination hall is a war zone, I get it, but you got to still pay attention so you don't miss those little keywords. And don't go memorizing just one treatment for pneumonia, as evidenced by my content right here. You see now that we have different variations of pneumonia, and that is why it looks like there's a lot of pneumonia questions on the exam. That is because pneumonia is dissected into different areas. Now we are now done with HAP and CAP coverage. You're wondering why I have mixed typical and atypical antipsychotic care. I don't want you to go too much into psychiatry. Okay, I don't want you to go too much into psychiatry, but there are 2 questions, 3 or 4 questions here and there that will show up on psych, and that we expect you to know, because a lot of times our patients also get agitated and stuff, and we tend to give this antipsychotic. That is kind of how it links into your own department. Okay, so know this basic. This is tiny piece of psych. Know that there are 2 main types of antipsychotic. We have typical antipsychotic, we have atypical antipsychotic. Our typical antipsychotic sounds like this: alloperidol, chlorpromazine, fluphenazine, perfenazine. Then we have main action is the D2 blockade. The advantage, very effective for positive symptoms like hallucinations and delusions. Let me quickly give you a way to remember it. Typical, we call it 1st generation. Atypical, we call it 2nd gen, right? Okay. With typical, we are only blocking one thing. We're only blocking dopamine. We're only blocking the D2. With atypical, it's called the 2nd gen. And guess what? We're also blocking 2 things. We are blocking D2 and we are blocking 5-HT2A. Do you see it now? So you will always remember that there are 2 things being blocked. In our 2nd gen, there's only 1 thing being blocked in our 1st gen. So 1 to 1, 2 to 2. That will help you remember. Now, this is the significance of that. It's extremely important. Where we are blocking just this D2, extrapyramidal side effect is going to be so bad, because we are blocking D2 at a very greater percentage, 80%. Now, this one right here, we're not only blocking D2, we are blocking something else with it. So the extent of the blockade is less. So we're only blocking dopamine at 60%. So that means what? We're going to be experiencing some metabolic syndrome like weight gain and diabetes and hyperlipidemia. That is now the exam. You got to know that atypical antipsychotic will cause what? Extrapyramidal side effect. No, sorry. 2nd gen will cause what? Metabolic syndrome. 1st generation will cause what? Extrapyramidal side effects. That is it that I want you to know. So if they ask you on the exam, olanzapine, somebody's on olanzapine, they have metabolic syndrome, that is the culprit. You want to discontinue olanzapine. Olanzapine, for obesity. Now let's talk about extrapyramidal side effects. Extrapyramidal side effects that we get from right here, from giving our patient 1st gen. We can also get EPS given our 2nd gen, but it's very notorious with our 1st gen. EPS now is a big umbrella that have many things underneath it. What do we have underneath EPS? What do we have? Is a list of things. We do have what? Acute. So imagine an umbrella. The top of the umbrella is called EPS. Underneath the umbrella, now we have the babies. Underneath that umbrella, now we have acute dystonia, akathisia, akinesia, Parkinsonism, tardive dyskinesia. So we have all kind of APSs, but these are the most common ones. Don't worry about the hours to day, days to months. Just be familiar that, okay, I do that with if I see a patient, one of my ICU patients going through akathisia, dystonic reaction, I have to recognize it, because I'm going to see that they're going to complain that they have neck, or they have spasms on the neck, jaw, and eyes. They have oculogyric crisis. How do we manage IM or IV, benztropine or diphenhydramine? Now with akathisia, we're going to see inner restlessness. They just can't sit still. You go to the DMB before, you saw those people beside you, and they're just shaking, looking left and right, and you're like, keep your legs still. I mean, I'm just thinking, you're thinking it out loud, but maybe they can't help you. Maybe they're taking antipsychotic. They have this inner restlessness. Beta blocker is the best drug for those people, propranolol. Parkinsonism, bradykinesia, rigidity, tremor, shuffling gait, benztropine, amantadine. These are the good drugs to give for somebody with Parkinsonism. Tardive dyskinesia is really pretty much nothing much we can do, but there are some new drugs right now like VMAT2 inhibitor, like valbenazine. They are very, very helpful in keeping things down. They said it works, but it's extremely expensive. So that is kind of, I will not lie, you have too much to worry about. You still have the general pathway to worry about. You have the acute care concepts to worry about. You have the roles and leadership to worry about if you're taking ANCC, especially. Not when you are taking ANCC, AACN, you don't need to worry about roles and leadership like that. But because you have that to worry about, don't put too much weight on psych. And if you look at your exam content outline, there are 4 main systems that are heavy: cardiovascular system, respiratory system, neurological system, and endocrine system. Those 4 systems are heavy. You want to study based on percentage. You want to focus on the heavy parts. That's what I do in class. And then the small things now follow, like the immunology, like the hematology, and those small things. But we need to focus on the heavy ones first. So you want to focus your weekend on respiratory therapy, disorders if you have the time. And I wish you a very, very, very happy holiday. But we're going to quickly wrap this up right here. And if you have any questions, let me know. If you are ever confused about community and hospital-acquired pneumonia, I hope today's lecture has been able to kind of shed more light and to what really goes on there and how it works. Do we have any questions at this time?